I think as we look forward, the challenges are not acute like that. The challenges are more so around regulations, around reimbursement, some of the traditional barriers that have inhibited providers from engaging. Now, during COVID, there were a lot of waivers of regulations and waivers of certain restrictions on reimbursement. Our goal now is to make permanent those waivers that make sense. Not all of the waivers will remain. For example, the waiver of enforcement of HIPAA, we expect to go back, and that should go back. But many of the waivers, like the waiving of CMS's site and geographic restrictions for reimbursement, we've been working on that change for a long time and are focused on keeping that there. Elderly patients should not have to be in a rural area and not have to present themselves to a clinical site to obtain telehealth and have it reimbursed. This is a remnant of a different time. High quality, robust care can be delivered to a patient wherever they are on consumer grade devices.
Yes, it's my understanding that CMS waivers were quite instrumental here. An alternate history would be that those restrictions weren't waived, and I'm not sure whether we would be talking about the rapid uptake of telehealth if they hadn't been. So one just has to conduct a little thought experiment. So let's just discuss HIPAA waiver. You just said that you think that that waiver ought to end. So my understanding is the HIPAA waiver allowed physicians to use sort of platforms that weren't special to telehealth to communicate with patients. I'm not sure whether extended to Zoom, but maybe.
Yeah, I think the way I would describe it is that they allowed providers to use technologies that are not traditionally HIPAA compliant, as long as that use is in a good faith effort to provide care during the health emergency.
So that meant some of these encounters took place over Zoom, correct?
Yeah, Zoom or FaceTime or other non-medical grade ways of interacting by video.
So why do you think that waiver should end? Surely the ease of access was something that made the uptake of telehealth possible and sort of seamless for people. Why do you think that should end?
Well, I mean, HIPAA is there to protect patients and their personal health information. And, I think we're all aligned with that. I mean, some people sometimes quibble with some of the challenges in maintaining HIPAA compliance, but I think we're all aligned that we don't want our personal health information sitting on servers at Apple, for example, which it very well may be right now if you've used FaceTime for a medical visit. There are certain protections like that are in place for I believe, good reasons. Now, the point you're making about ease of use and all that is a very important point. And I think that we all recognize, and I think we heard loud and clear from providers who were newly engaging in telehealth during the COVID pandemic, that ease of use is now a priority. It was a year ago, prior to COVID, the priority for most providers was interoperability. When COVID hit and they needed to engage, all of a sudden ease of use became higher up in the priority order in my experience. But the issue, I think the idea here is you can have both. You can have ease of use and HIPAA compliance. We developed another version of our platform we call Amwell Now, basically to satisfy both of those needs. It's HIPAA compliant, just like all of our technology is, but it's built to be simple and easy to use. Not full of bells and whistles, not all about interoperability and multiple levels of complexity, really about ease of use. And there are other examples out there in the marketplace.
Not to be argumentative, but ending the HIPAA waiver would advantage companies like Amwell, because you have medical grade HIPAA compliant products to sell.
Sure.
So Is there going to be a fight over that, do you think?
I don't see it that way. I mean, during the COVID pandemic, many more companies entered the telehealth space. All of a sudden, our traditional competition may have been Teladoc and others in the past. Now our competition is it may very well be Microsoft Teams and Zoom and all of these other folks. They're well within their rights, and they have plenty of coders to make sure that their products are also HIPAA compliant. So I wouldn't worry about that. I think that the way we see it is, regulations exist for certain reasons. If you wanted to see a physician, but he or she didn't have a license to practice, you might be taking a chance. There may be a reason why licensure to practice is a requirement legally. And I see HIPAA as the same way, simply protecting your PHI. In this age, we give away a lot of our private information, not our health information, but just private information every day on the internet. And privacy has become a bit cheapened, in my opinion. But I think that consumers ought to be concerned about their health information going to the wrong people.
So I think there've also been some waivers that allow for audio only exchange between providers and patients. Are you in favor of continuing to allow that as something that would be reimbursable?
Yeah, I want to first start by clarifying that we are a company that is always focused on, whenever possible, a live synchronous audio video interaction. We believe that that's the most robust way to interact with a patient electronically. Having said that, there are occasions in which that's not possible. The patient may have outdated technology. The patient may be in a rural area where broadband is not available and they're on a cellular device. I think our view on that is that number one, each modality of interaction has its own should have its own guardrails in terms of how you can or cannot meet standards of care. And so I think that's where we start, is you need to know your modality and understand your limitations. For example, nurses perform triage by telephone and have done so for many, many years now. And there is a whole science behind telephone nurse triage. There are guidelines and manuals and all of that. It can be done safely. You just need to be careful because you can't see the patient, number one. And a nurse has to operate within his or her license requirements, number two. Now, having said all of that, we do support enhanced telephony or an audio-only experience being a reimbursable event, as long as the provider meets standards of care and is providing a good and well-documented interaction. I think I intentionally used the word enhanced telephony because I want to distinguish that from a pure phone call. Enhanced telephony or audio-only telehealth means that there's still data about the patient available to the provider in a past chart or an intake form, that the provider has the ability to document properly what has occurred, that documentation can be shared, and that other elements of a normal visit, like submitting codes to a payer, e-prescribing if it's appropriate, and if the provider is a prescribing provider, all of those elements should be in place. But when those are in place, we are in support of that being a reimbursable event.
So not just simply a phone call, but something that an audio encounter that would have to be conducted over a medical grade platform like
That's right.
or one of your competitors.
There are many out there, sure. And I would also say that we're sensitive to concerns about fraud, waste, and abuse. And so this, some of this methodology is to ensure good quality care. But some of this methodology is also to be able to document that a valid visit occurred, that record can be auditable by the payer at their request, and those sorts of things, because we are not here to be a pill mill. We're not here to encourage or to facilitate anybody to practice bad medicine or fraudulent medicine. We're here to support good, high quality care.
So as you know, as at least it's sort of one of my axioms, that nothing happens in healthcare unless it's paid for. And of course, you know, the waiver of some of the payment rules, and the private insurers also agreeing to pay for telehealth. So, are you, from where you sit, are you confident that that telehealth will continue to be paid for after the public health emergency is over, both by the public payers like CMS and Medicaid, but also by private payers?
So I'll be perfectly honest with you, Peter. I have no crystal ball about all the decisions that will be made. None of us do. But you know what? The progress is moving always forward in telehealth, and I believe it will continue to move only forward. Another way to say it is there's no putting the toothpaste back in the tube. Providers recognize the value of telehealth. Patients recognize the convenience and access and other value afforded by telehealth. And telehealth is becoming a standard way of practicing healthcare, not an offshoot of healthcare anymore. So we expect nothing but progress going forward. There may be bumps in the road. We have to work very hard in educating lawmakers and regulators as to what can be done safely and effectively. But we believe that the future looks really bright.
So we only have a few minutes left. I wanted to change the topic just slightly as we wrap up here. Telehealth could, it seems to me, exacerbate healthcare disparities. Affluent people have good Wi-Fi, they have fast computers, or the latest cell phone. They also may, you know, health literacy may come into play here. It may be easier for somebody who's privileged and educated to talk through a medical issue remotely with the provider than it would be for somebody who lacks health care literacy and maybe is just a little bit ill at ease with healthcare, and then, you know, add the layer of the encounter taking place in sort of a two-dimensional way. Maybe we'll get to virtual reality telehealth, but that's another conversation. So is Amwell doing anything in any sort of focused way to, well, I guess that it's a two-part question. Do you acknowledge that maybe this could be a problem, and is Amwell doing anything to address it?
Absolutely. Very good question again, Peter. Listen, these health disparities exist in all settings. And health disparities could be based on income. They could be based on where you live and what your broadband is. They could be based on whether you have transportation or your access, your local access, depending on in what type of an area you're living. Our goal at Amwell is to democratize healthcare, to make the same healthcare available to any consumer, and to try to mitigate the limitations. And you know, I'll give you an example. Why should somebody with cancer, why should their care be dependent upon where they live? And if they live in a rural region where they have to travel an hour and a half just to see an oncologist, and that oncologist, no offense, is to any institution, but is at a general hospital, not a tertiary care center that specializes in cancer care. Why should not any American be able to get a consult or even receive care from a place like Cleveland Clinic, from a cancer center in general, regardless of where they live, regardless of their health insurance? That's maybe a bit idealistic, but that's the way we look at the world. We want to make sure that patients can access care from a multitude of centers, from a multitude of specialty types if specialists are required, improve their access to just general care in the after hours. So that's really our one of our core missions. And I would say, you know, we've taken a number of steps, whether it is improving accessibility for those who are visually or hearing impaired, adding a roster of of translators for language. We have done work through the Alliance for Connected Care, working with the FCC on improvements in broadband in rural regions so that internet itself is not a barrier. We've done work to ensure that our app can work on normal cellular frequency, or normal cellular bandwidth, that you don't even need necessarily broadband. And again, falling back to just plain old-fashioned phone if you can't. Somebody can use a plain old-fashioned wall phone and call our customer service center. They will enroll you into our platform and get you into a visit. It will be an audio-only visit, but they can get you into a visit. So these are some of the efforts, and there are others that we're considering to level the playing field and to improve access. We also, one last thing I should mention, we also do work with a number of Medicaid plans to improve access to the Medicaid population specifically.
That's encouraging. I guess I'm still left with a little bit of worry that that the digital divide is just a little bit harder to bridge than maybe many of us imagine.
We're sensitive to the point you're making, and while we can't solve that problem ourselves, we're cognizant of that. We're constantly looking at ways that we can make it easier, and I think time is on our side. I think that we think of smartphones. Those of us of our generation, we think of smartphones as this new modern invention. Give it 5 or 10 years, and we'll have children who have their own smartphone who were born in the age of smartphones, it will just become so normal.
I think that's already happened, actually.
Or maybe it's already happening. There you go. Yeah. So technology really is only making these things easier, and even still, like I said, all it takes is any smartphone, any web browser, cellular network, and you can have a live video visit today in most cases.
Well, good. Well, thank you for the time today. This has been a fascinating, wide-ranging discussion. We'll be keeping an eye on Amwell and its stock price in the days ahead. And of course, telehealth seems like perhaps one of the most disruptive things that's happened. Disruption, an overused word, but it certainly seems one of the most disruptive.
Clayton Christensen.
Yeah, it seems to be one of the most disruptive things that's happened in American healthcare in recent memory. So much more to come. So thank you.
Well, thank you, Peter. I really appreciate. I really enjoyed the conversation we've had, and it's an exciting time. We're really excited to be a part of modernizing, helping to modernize how we deliver healthcare.